So today we are going to discuss the venous drainage or the surface anatomy in case of portal hypertension. You know, portal hypertension is a very serious disease. It occurs in cirrhosis, and you know, hepatitis, it is transmitted from the mother to the fetus 90% during delivery, and that develops as chronic hepatitis in a 9 to 10-year-old child with jaundice and with the symptoms of petechiae or all the symptoms of hepatocellular failure in a 9 to 10-year-old, and then it will go to cirrhosis in the second or third decade. During that time, there are two liver biopsy specimens which show, one is piecemeal necrosis, the next is bridging necrosis. What is piecemeal necrosis? You know, there's a portal vein in the center of the hepatic lobule. The portal vein and the hepatic lobule, it's the lobule, and in the center of it there's the portal vein. Now, in case of chronic active hepatitis, you see rosette formation. Rosette formation means small clumps of lymphocytes and macrophages and are collected over there. That is inflamed. The liver is inflamed, and so you get rosette formation in the area between the central portal vein and the hepatic cell border. And this is chronic active hepatitis. Bridging necrosis is these rosettes, they conglomerate to form a bridge between the portal to the hepatic border. Outside the hepatic border is the biliary sinusoid, the bile, which is formed. The hepatic cells are lying in the bile, and in the center is the portal vein, and so this portal venous pressure, if it is increased, whether it's called the wedge hepatic venous pressure, WHVP, wedge hepatic venous pressure, which is increased in cirrhosis. You must not allow the baby to go to that stage. You must not. There are 101 medicines available. You can give it antivirals, you can give it very early, and you can curb this tendency to go to cirrhosis or go to chronic active hepatitis or chronic persistent hepatitis. So this venous drainage in children, it's a marker. It will show you which babies need intervention. So if we think of the surface anatomy, we know that there's the umbilicus. Everybody knows where the umbilicus is. Everybody knows. So if you draw a straight line from the umbilicus, that corresponds to the 10th thoracic vertebra, T10 level. 10th thoracic vertebra, it goes hand in hand with the umbilicus. Veins above T10, they drain to the superior vena cava, that is through the axillary veins, and the veins below T10, they drain to the inferior vena cava through the femoral veins. The superior mesenteric vein and the splenic vein conglomerate to form the portal vein. That goes to the liver. So the portal vein is formed by the superior mesenteric vein and the splenic vein. So portal hypertension means the wedge hepatic venous pressure is raised. That is, wedge hepatic venous pressure is below the liver. Below the liver, the part of the blood which is going to the portal vein, there the pressure is raised. Normally it is 7 to 10 centimeters of water. If it is 12 or 13, it is raised. Wedge hepatic venous pressure, if it is 12 or 13, it is raised. Now, this surface anatomy, we know that in portal hypertension, what happens? Portal hypertension, you get the three places you get systemic and the systemic veins and the azygos veins, they conglomerate. Azygos vein will conglomerate with the systemic vein at the lower end of the esophagus and cause esophageal varices. Esophageal varices bleed. They bleed. And the child may come with hematemesis or melena. Child may come with severe hematemesis or melena. And there are several drugs to manage it. But you need to see the varices through a esophagoscope, a pediatric esophagoscope, and that is introduced to see whether there are small humps around the esophagus, showing that esophageal varices are present. Similarly, at the lower end of the rectum, the superior rectal, it conglomerates with the inferior and the middle rectum arteries. And there also you get varices. And from there you get the hemorrhoids. Hemorrhoids may bleed from there. Internal hemorrhoids, external hemorrhoids. So it can bleed from there. You will get clay colored stool you can get, or you can get frank bleeding, melena may be present. How do you differentiate melena from normal stool? If you pour water on the stool, we say when you wash fish, you get a fish colored, that colored water, light red colored water. That colored water will come out of melena. Hard black stool is not melena. Melena is always soft black stool. Soft semi-solid stool with black color is always melena, and you pour water in it and a light reddish water comes out. That is melena. So how do you diagnose it? From the surface anatomy, I told you all the veins above the T10 are draining to the superior vena cava, and all the veins to the below T10 are draining to the inferior vena cava. So only in inferior vena caval obstruction, only in inferior vena caval obstruction, if you see the flow of vein, in the veins below the umbilicus, the flow will be from below upwards. From below upwards. That is towards the umbilicus. In portal hypertension, it is always away from the umbilicus. That is, the normal venous flow is maintained. Why? Because the umbilicus is the portion where the mother was connected to the baby. Remember, in utero, from the placenta, the blood was coming through the umbilical arteries and was draining through the umbilical vein, and there was a ligamentum over there attaching to the portal vein. There was a ligament, and that is called ligamentum teres. It is obliterated at birth. That is called ligamental teres. In case of portal hypertension, that becomes active and the portal vein comes from that and goes out through all the ways. Because the umbilicus is the place where the umbilical vein, that is the placenta, used to give nutrition through those umbilical veins and arteries. So only in inferior vena caval obstruction do you get the veins below the umbilicus. They will flow from below upwards. Below upwards in the veins only below T10. The upper veins will be normal. But in portal hypertension, the venous drainage will always be normal. Why? Because the ligamentum teres has become patent and it is draining the portal vein, and you can get the veins are all flowing in the normal direction. This is all.